Hello, my name is Athena Pefkarou and I'm a Pediatric Hematologist-Oncologist. I'm the director of the Sickle Cell Comprehensive Care program at the Cancer and Blood Disorders at Nicklaus Children's Hospital. Today, I'll be talking to you about sickle cell disease with emphasis on the medical achievements in improving the morbidity and mortality in patients with the conditions. Sickle cell disease is the most common genetic condition in the United States. There are over 100,000 people living in the States with this condition, and they are primarily African Americans, and the remaining ones are Hispanics. 8% of all African Americans have sickle cell trait, and 1 in 363 babies born every year have the condition. Among Hispanics, 1 in every 16,300 are born with sickle cell disease. Geographic distribution is shown in this map, where the green represents sickle cell disease and is primarily seen in Sub-Africa, in Sub-Saharan Africa. Overall, there are over 20 million people inflicted with this disease worldwide. In Sub-Saharan Africa alone, there are over 300,000 babies born every year with the disease. The second map, which is one of the states, shows which states have the highest population of individuals with sickle cell disease. They are the ones in the dark brown, with Florida, the leading state with close to 40,000, followed by New York State, followed by California, Georgia, Michigan, and North Carolina. The life expectancy of patients with the disease has really improved dramatically, as you can see in this graph. Unfortunately, it still continues to be 20 to 30 years less than the average population. Back in the 70s, less than 10% of children would actually survive into adulthood. Now, the exact reverse is happening. Less than 10% will demise. The remaining will be transitioned to adult programs. The majority will be able to hold jobs, marry, have a relatively free of symptoms life, and some of them may even have children. Let me see the next slide. What I would like to talk to you as we go along is what really has led to this improvement. Diagnosis and genetic counseling is of most importance. Newborn screening has become universal following the 1987 publication by NIH with guidelines for screening. Once the diagnosis is made on newborn screening, it's very important that the diagnosis is confirmed as early as 4 to 6 weeks of life, so that preventive measures may be implemented as early as 2 months. The way to do that is through hemoglobin electrophoresis. Hemoglobin electrophoresis will also distinguish between the various variants of sickle cell disease. In this slide, you see the 4 common variants in the United States, with SS representing close to 70% of patients, SC 20% of patients, and S-beta thalassemia plus or 0, the remaining 10%. SS and S-beta 0 are the two most severe variants. And when people talk about sickle cell disease, invariably refer to these two variants. SC is less severe, and S beta plus is the least severe. There are some other variants in the United States seen, but rather rarely. Those are SO Arab, SD, and S beta, and S high fetal hemoglobin persistence. This particular slide shows under light microscopy on the left the morphology of red cells in SS with a lot of sickle cells there, the trypanocytes, and on the right what is seen in SC, and to a similar degree what is seen in S beta thalassemia, where there is prominence of target cells rather than anything else. Once the diagnosis is made, as I said already, this is the time to provide genetic counseling to the family. If the parents do not know their status, they must be strongly advised not to have another pregnancy until they have their own hemoglobin electrophoresis and their own status is confirmed. For those parents who do know whether they have S, C, or beta thalassemia trait, they must be offered prenatal diagnosis. It's imperative that they understand that the earlier the diagnosis is made, the better they are going to be able to make a well-informed decision of the future of the pregnancy. They need to be made fully aware that termination of pregnancy for genetic conditions such as sickle cell disease are only legal up to 20 weeks of gestation. In sickle cell disease, the diagnosis may be made as early as 10 weeks of gestation by obtaining a fetal sample from choroid villus, and by 16 weeks by obtaining amniotic fluid, because by 16 weeks you are going to have enough amniotic fluid present. Both procedures are quite safe. There is no danger to the fetus, and the diagnosis is made on DNA of fetal cells, and it's very accurate. I would like to pause and talk to you about sickle cell trait. In general, sickle cell trait is a benign condition. Individuals may go throughout their life without even knowing they have the condition. However, a number of people with the trait, starting in the second decade of life, may show signs of kidney problems. These will manifest themselves as inability to concentrate urine, proteinuria, painless hematuria, increased incidence of urinary tract infection during pregnancy, hypertension, and in rare occasions, renal cell carcinoma. To this day, there are no guidelines about surveillance in patients with sickle cell trait. I would like now to go on to talk to you about preventive measures. For starters, identifying risk factors and recognizing early signs of complications by implementing preventive measures, you will be able to improve the quality of life and decrease morbidity and mortality. In general, streptococcal pneumonia infections, which are very common in the first 5 years of life, can be life-threatening for children with sickle cell disease. Back in 1996, Dr. Marilyn Garson carried out a study where she had a group of children that were given penicillin prophylaxis starting early in infancy, and a group that they were given placebo. Very soon, she demonstrated convincingly that there was a decrease in sepsis and severe pneumococcal infections by 84% in the children that were on the penicillin prophylaxis arm. It was also demonstrated that continuing the prophylaxis past the age of 5 years, it didn't really make that much difference. Therefore, penicillin prophylaxis became standard of care right after that, and it's been implemented ever since. In the first 3 years of life, starting at the age of 2 months, the dose is 125 milligrams twice a day. By the age of 3 years, this is increased to 250 milligrams. And at the age of 5 years, routinely it is discontinued, provided the child has completed all immunizations against pneumococcal sepsis. There are 2 groups of patients for whom continuation of the prophylaxis for life is mandatory. These are patients who either had a documented severe sepsis episode due to pneumococcal bacteria, and the other group are children who underwent splenectomy. There wasn't enough proof that patients with SCIP and S-beta plus benefited from penicillin prophylaxis enough to make it mandatory. However, the majority of physicians in the United States, including myself, we like to give it to all variants of the disease. And this brings me to immunizations. The standard immunizations for children in the United States have been including Prevnar 4 doses, Prevnar 13, 4 doses in the first 2 years of life that gives adequate protection for pneumococcal. This is for the standard population. When it comes to children with sickle cell disease, they need extra prophylaxis, which is provided by Pneumovax 23 strains, and we give 1 dose at the age of 2 years, a second booster at the age of 5 years, and then a booster every 5 years into adulthood. It's also been demonstrated by CDC that children that are immunocompromised, and that includes children with sickle cell disease, have a high risk of developing meningococcal sepsis. It is now recommended that such children should receive 2 doses of the meningococcal vaccine between the ages of 9 and 23 months, and then receive a booster 3 months after the second dose, and then a booster every 5 years. I would now like to move on to screening tests that are important. All body organs may be affected by the disease. There are, however, 5 organs that are most sensitive. These include brain, spleen, kidney, eyes, and the femur and the head of the femur. Brains are the ones that are most vulnerable. 11% of sickle cell patients will develop an overt stroke, and another 20 to 40% will develop a silent stroke by the age of 18. Silent strokes can be very difficult to identify. They have very subtle features. In general, if a child with sickle cell disease has developmental delay, poor school performance, or deteriorating school performance, it should be suspected that the child may have sustained silent strokes. Back in 1998, Dr. Adams demonstrated by the use of transcranial Doppler study, TCD, that the mean maximum pressure velocity in the middle cerebral arteries and the distal internal carotid arteries were a good predictor of which child is at high risk of developing a stroke. And from his study, anybody with a velocity more than 200, it's definitely at a high risk. Following that study, TCD became standard of care on a yearly basis between the ages of 2 and 16 in all children with SS and S-beta 0 thalassemia. The NIH study STOP demonstrated that the children who are at high risk, as demonstrated by TCD, when put on chronic transfusions, the incidence of strokes decreased by 80%, and the abnormalities on the TCD reversed within 6 to 12 months. It also demonstrated that if you discontinued the transfusions after 2 to 3 years, unfortunately, everything is back to where it was before. The TCD becomes abnormal and the incidence of strokes would go up again. Therefore, once you commit to receiving chronic transfusions, you should expect that this will be for life unless you are cured by a bone marrow transplant or hopefully in the near future by gene therapy. Other tests of importance include echocardiogram, which will predict if the child is developing pulmonary hypertension. We recommend them after the age of 10 years. Eye examinations, also recommended after the age of 10 years, because proliferative sickle cell retinopathy can be very harmful, leading to vitreous hemorrhage and retinal detachment, which can lead to blindness unless recognized immediately and treated by laser, which will prevent the loss of eyesight. Urinalysis is very important because it will detect inability to concentrate urine, proteinuria, increased incidence of urinary tract infections, damage to the renal tissues, and development of nephrotic syndrome. Unfortunately, it is very important that this monitoring happens because sickle cell disease at a variable fashion will lead to tubular dysfunction and papillary necrosis in anything from 5 to 20% of children with sickle cell disease. I now would like to move on to family and patient education. We already talked about genetic counseling and diagnosis, but we still need to educate parents, not only at that time, but on an ongoing basis for the rest of their life and the care of their children. They need to understand that their contribution is essential for the better well-being of their child. They need to understand how to recognize dactylitis, splenic sequestration, be alerted to fever, make sure they give the penicillin, understand the signs of priapism, understand the early signs of stroke. All of these things are extremely important. They need to know how to prevent pain by good hydration and avoidance of extremes of temperature and excessive exercise. Then we go on to contraception and pregnancy. Sickle cell patients will get pregnant just like anybody else. Contraception is essential because pregnancy is dangerous to the life of the patient. However, contraception has to be selective to avoid increased incidence of thrombosis. And for that, using progesterone-based hormone contraception is the one recommended. Pregnancy is dangerous. It leads to toxemia, pyelonephritis, thrombophlebitis, spontaneous abortions. The mother will probably need transfusions during pregnancy, and if she's an opioid addict, her baby will suffer from opioid withdrawal. I would like to move on to the next section, which is recurrent treatments. The cardinal pathophysiologic features are chronic hemolytic anemia and vaso-occlusion, which will lead to ischemic tissue injury. Among acute complications, as you see here in this slide, with some demonstration with some pictures, painful crises are the most common problem that will lead to frequent and prolonged hospitalizations, a lot of morbidity, and unfortunately is a challenge for patients developing an addiction to opioids. Acute chest syndrome, it's a very serious problem. It has now surpassed infections as the leading cause of death in patients with sickle cell disease. Unless you're looking out for it and you detect it early and become aggressive with your therapy, it can lead to death. Many of these patients will need emergency exchange transfusions, ventilatory support, and other intensive care in intensive care units. Infections, though markedly improved since the penicillin prophylaxis was started, they're still a major problem. Parents need to seek medical advice for fever over 1 or 1.3 and expect that their child most probably will finish up being hospitalized for fever more than 103.1. Emergency rooms have well-established protocols for managing patients with sickle cell disease and fever, with the cardinal goal to give antibiotics within 30 minutes from arrival to the emergency room. Other problems, splenic sequestration, for instance, it will lead with a very sharp decrease in hemoglobin, throwing the patient into a heart failure and endangering life unless you transfuse immediately. And in recurrent cases, sometimes when we're not able to control them with chronic transfusions for 6 to 8 months, we may be forced to proceed with splenectomy, even in children less than 5 years when it's really not a desirable time to do a splenectomy. Dactylitis, as you can see in this picture, it's a very painful event, and when it recurs, it will lead to very short digits, both toes and fingers. Stuttering or recurrent priapism will lead to impotence and acute renal failure. It's a common problem when there is multi-system failure in severe sepsis, and unfortunately, very often it will lead to chronic renal failure. I would like to move on now to the modifiers. And for starters, we have transfusions. We have 3 types of transfusions: episodic or acute transfusions, which are given as shown there for acute chest syndrome, acute anemia, for such as sequestration, prolonged painful crisis, for fever. Then we have chronic transfusions, which are recommended for some recurrent acute chest syndromes, but primarily for abnormal TCD, and 4 established strokes. And finally, we have exchange transfusions, which are recommended at the time when a stroke develops and the patient is symptomatic for the first time, for patients with severe acute chest syndrome and prior to emergency surgery. Some patients who are on chronic transfusion, because they have very high ion load in their liver, they also qualified for exchange transfusions. Chelation of iron is imperative when the ferritin level reaches 750 to 1,000, and we have 2 agents available, both oral, Desferal and Gedenu. I would like to alert you to the fact that though we monitor effectiveness of chelation with a decrease in the ferritin level, the real accurate way of measurements of improvement is by liver biopsy and by liver ferriscan. I would like now to move on to hydroxyurea. Hydroxyurea has truly revolutionized the management, the quality of life, and the future of patients with sickle cell disease. It was in 1980 that hydroxyurea, a chemotherapeutic agent primarily for patients with acute myelocytic leukemia, was shown to have anti-sickling effects, qualities. And it was used for a good 20 years before the FDA approved it for children in 2000, since when we have been using it in children. It works in a number of ways. It leads to increased fetal hemoglobin, decreased white cell count and reticulocyte count, decreased adhesiveness of the vascular endothelium, decreased hemolysis, increases the size of the red cells, and therefore decreases the inflexibility of the sickle cells. Following the baby HAG study, which was completed about 5 or 6 years ago, we now know that hydroxyurea, if given to children with SS and S-beta 0 thalassemia starting at the age of 9 months, they are going to have a much better quality of life, and we are doing that routinely these days. Clinically, the child will experience less painful crises, less and shorter hospitalizations, less acute chest syndrome, better hemoglobin, better stamina. Though there are no randomized clinical studies to demonstrate that there is decrease in strokes, we do know that children who start in infancy have not been having strokes at the same rate as they used to before. The side effects are very manageable. The medication is not expensive, but unfortunately is still very underused. The only other medication that is available is L-glutamine. L-glutamine has been demonstrated to improve stamina and decrease painful crises. How it exactly works is not really known, but is most probably due to its antioxidant activity on the sickle cells. Finally, bone marrow transplantation. Only 5% of children with sickle cell disease have a match-related donor among their siblings. Those patients, however, are the lucky ones, because if they go to bone marrow transplant, they will be cured of their disease. And with the refinement of the procedure over the past few years, it is a relatively safe and promising procedure. In addition, if you don't have a donor, you could have a haploidentical from one of the parents or from the registry from a non-related individual. However, those have a lot more complications and they are not yet considered standard of care. For all babies, when diagnosed, I like to get their HLA typing if they have siblings and refer them to bone marrow transplant as early as possible, because the less transfusions, and the less tissue damage has occurred, the more likely we are that the procedure is going to be successful. As far as the future is concerned, gene therapy, I would like to say, is around the corner. Gene therapy will eliminate the need for a bone marrow transplant and its complications, and will not need to have a donor. The way gene therapy is going to work is by either eliminating or modifying the mutated gene. There have been isolated cases in adults where it appears to have been successful. There are several ongoing trials in the United States for children, and we anticipate that in the next 4 to 5 years, we will be able to offer it to a lot of our patients with sickle cell disease. With that, I would like to stop. Thank you for listening, and ask you to give us a call or email us if you have any questions. Thank you.
Perfect. Great job.
We did better this time, right?
Yeah,
Yes.
yeah. You did great.